Good afternoon, everyone. This is Ned Ellington from ONC. Want to welcome you to the ONC grantee call for Stage 2 Meaningful Use. Let me start off by doing one couple things. First off, I want to thank Matthew from NeHC. NeHC, is, as you guys know, has been a great partner with ONC. They've been hosting the open public calls, and we asked them to jump in and help us with the grantee-only call. So just wanted to acknowledge Matthew and let Matthew, Matthew's going to give you a few instructions on if you're not used to go to webinar. Matthew?
Absolutely, and welcome everyone. Just a really quick overview of answering or asking questions during the webinar. On the right-hand side of the screen, you should see a question and chat box. If you type in your question, we will filter it over to Ned, who will then aggregate them all and ask the questions. If you would like to download today's slides, they are available at www.nationalehealth.org/final-rules all together, and you will be able to download the slide deck from today. I'll turn it now back over to Ned, and then we can get started with the speakers.
Matthew, thank you so much. First off, some folks may say, well, okay, why are we doing a grantee-only call since we have broadcast to the world, if you will, the other calls? And very candidly, we asked Steve and Travis to give us an overview, but allow some questions. We're going to be interacting over the next 2 years with this, and I thought it would be good to have sort of a casual conversation, not with the whole public involved with it, but specifically from our ONC grantees' perspective, and knowing that we're going to get questions from the field, knowing we're going to be interacting with a lot of folks, and so maybe give us a little bit of a heads up. So that's the purpose. It's more about getting your questions answered, so as much as we can. We've asked both Steve and Travis to reduce their comments, and again, if you have not attended one of the other NeHC calls, then you can download yesterday's webinar where they went through the rule in greater detail. And I would encourage you to do that. And I would encourage you to go to the CMS site, the ONC sites, and download the fact sheets and all the presentation, all the materials have been presented to try to help communicate the changes in Stage 2. And I know we'll all be doing that to communities of practice and over the next many months. But this was a chance just to have an initial conversation with these two guys. We're going to switch the order. I'm going to ask Steve to go first and talk about the ONC rule, and then we ask Travis to come back in and talk about the incentive rule, what I call the incentive system rule, and then we'll open it up. So I'm going to be monitoring questions. Feel free to pose them as we go along. And the thought here is, after the presentations, we would ask them both to address questions you sent in. So with that, I'm going to turn it over to Steve.
All right, thanks a lot, Ned. Thanks a lot for everyone for joining us in the unplugged version of our presentation. A little bit more of a virtual, intimate setting here that we've got. So thank you all for taking some time out of your day to present. Sorry if I sound a little nasally. I have some type of sinus thing that has affected me thus far. So I do want to thank all of you again for commenting. For those of you that participated in groups or individually commented on the rules, they really helped us, both ONC and CMS, put together our final proposals and better understand folks' concerns and constructive criticism as well as positive remarks. The thing I will caveat, even since I'm going first, I'll do Travis a favor as well. There are many factual questions that we can answer. To the degree that you have specific interpretation questions, those may be ones that we will need to just say thank you and take down a note for your comment, and then talk about them within the agencies to see what how we would need to further interpret the rules to provide additional guidance. So it may not be as rapid fire, precise answers for everything, but I think a lot of the questions that we've received thus far generally we've been able to answer pretty straightforward, with the exception of a few that have been very good, pointed, specific questions that we need to just go back and look at the rules in more detail. So that being said, I will carry forward, and I'm just going to focus on a couple things. You can go to my next slide. Just overall themes for ONC's rule that I think you can take away. A lot of certification focused on enhancing standards-based exchange, promoting safety and security, enabling greater patient engagement, and this is really in support of the technical capabilities that would need to be in place to make it possible for providers to meet those new Stage 2 objectives, increasing and introducing some greater transparency to the certification processes. I'll touch on that in a bit, and then just overall reducing regulatory burden and providing some additional flexibilities that I'll touch on as well. Next slide. So as you know, there are two agencies, two rules, separate, complementary, but they do have different scopes. So ONC's Standards and Certification Criteria rule really focuses on technical aspects, and to be more precise, our rule specifies the capabilities that EHR technology must include and how those capabilities need to perform in order for the EHR technology to be certified. It does not at all in any way specify how EHR technology needs to be used. That's where the meaningful use rule comes in. And I know I'm sorry if this sounds like a basic concept, but there's a punchline to these points here. So in the context of meaningful use and the scope, it really specifies, as you may know, how and what eligible providers need to do to use their certified EHR technology in a meaningful manner and get their incentive payments. And so the important takeaway between the relationship between these two rules is that if you try to interpret ONC's rule as a proxy for use and for how EHR technology could or should be used, there's a high likelihood that you would interpret ONC's rule incorrectly because it solely focuses on what EHR technology needs to do to get certified. So that's just an important point to keep in mind as you probably read both rules together. There are certain things that are focused only at meaningful use and certain things that are just focused in the Standards and Certification Criteria rule. Next slide. This one's more for your reference, pretty much showing between the NPRM and the final that not too much changed at a very high bird's eye view level of the certification criteria that we proposed. We've got the red and the green different numbers for the certification criteria in each of those categories under our Section 314. Next slide. These are tables, again, for your reference, and to save time, I'm not going to cover them too much, but they do follow process of just comparing to what I presented as part of the proposed rule and how things have changed in relationship to the final rule. So we can skip next, and we'll next slide. So I'm just going to touch briefly, I think, and most importantly for at the high level portion here of my presentation is really going to focus on how we redefined and revised the definition for certified EHR technology. So as you've probably heard when I've given other presentations, we referenced it in our rule. It's defined, and materials that we use, it's specified as a proper noun, and that's to show and to indicate that it has a specific meaning, as opposed to lowercase c, which could be any EHR technology that was certified. So we try, from a regulatory drafting standpoint, we've tried very hard not to use the phrase lowercase c certified EHR technology so as not to confuse people. So the main thing here to call to your attention and to keep in mind as we go forward with the rulemaking as it plays out is that under our July 2010 final rule, we had a policy and a definition for certified EHR technology that was driven by the certification criteria that we had adopted. And so you needed to have 100% of EHR technology certified to the applicable setting, ambulatory or inpatient certification criteria in order to have something that met the definition of certified EHR technology. And so, as we all know, that caused a lot of different tensions, especially for different providers on the EP side, especially that had different scopes of practice, requiring them to have or possess capabilities in order to have some EHR technology that met the definition of certified EHR technology that they wouldn't necessarily use to demonstrate meaningful use, either because they chose to defer a menu objective or because it was a core objective that they could, as a matter of fact, exclude or meet the exclusion for. So what we did in response to public comments was to propose a dynamic definition that would be driven by meaningful use, received a lot of wide support, and we've decided to finalize that proposal with a few modifications, and that has to do really with the timing and the flexibilities that we've introduced for when people can go to this new dynamic definition, and I'll have another slide that'll cover that, so I won't jump to the chase quite yet. Next slide. So this is a slide I used during the NPRM. Again, kind of a bottom line for your reference and as a nutshell to show. There's a definition that's subsumed by the overall Certified EHR Technology definition, which relates to the base EHR definition. And that's associated with certain capabilities and certain certification criteria that I'll touch on briefly in the next slide. But suffice it to say at a high level, this new revised definition as we go forward, everyone will need EHR technology certified to meet the base EHR definition. And then where the dynamic aspect fits in, where there's some additional flexibility, is with relation to the stage of meaningful use that a provider seeks to meet, as well as the core menu that they would need to include. And so I'll do a quick side note on the kind of different views to the definition of certified EHR technology. So from a provider standpoint, for those of you that are RECs or health providers out there in the general public, the definition for certified EHR technology gives providers an indication of what technology that they'll need to use in order to demonstrate correlated meaningful use objectives and measures. On the vendor side, it indicates to EHR technology developers what products and what software and what capabilities that they would need to package together to get certified in order to support the provider's achievement of meaningful use. And so there's a real tight interdependence between the software packages that EHR technology developers seek for certification and the flexibilities that providers would be able to achieve in terms of the quantity of EHR technology that's been certified in meeting this new dynamic definition of certified EHR technology. Next slide. So a lot of the slides that I have will, with images and other types of displays of how the certified EHR technology definition plays out, all have to do with respect to the quantity of certification criteria to which EHR technology is certified. And so that's a main point that we want to get across to folks as we go forward, is that no longer under this new definition will you necessarily need to have all of the EHR technology certified to all of the certification criteria to meet the certified EHR technology definition. And as I discussed in terms of the interdependence here, this last bullet, EHR technology developers have the opportunity to rethink the certification software that they bring, the EHR software, I guess you should say, that they bring forward for certification. And they have the ability now to really work with the regulation, take some innovative approaches in terms of what their customer needs may be based on stage, based on exclusions, etc., and come up with some right-sized certification offerings for their customers. So we really think that, and we really tried to work hard to create a regulatory framework now going forward that everyone can work with, and that will make it possible for EHR technology developers to do what makes sense from a business perspective and in support of their clients' achievements of meaningful use. Next slide. So the one thing to be excited about, the so what here, is this little clip art that I've got next to the single EHR module. So under the prior rule framework that we had, you could only meet the definition for certified EHR technology either through the use of a complete EHR or a combination of EHR modules that was equivalent to a complete EHR. So again, 100% of the certification criteria. Now with this new revised definition, there is the potential for a single EHR module that could be certified to the requisite number of certification criteria that would support a provider's achievement for either meaningful use stage 1 or meaningful use stage 2 of correlated objectives and measures. And so this is really an opportunity for people to, again, get those right-sized certifications. Next slide, please. So this slide, I'm sorry if it looks a little busy and it's got a lot of concepts on it, but I think the two main points that I'd like you to take away here, first and foremost being to remember that there are two types of certifications issued. Either a complete EHR certification, which by definition is EHR technology that's certified to all the mandatory certification criteria. We do have a few more that are optional this time around, and they play into the overall definition of certified EHR technology. But in large part, if an EHR technology developer gets the complete EHR certification issued to its product, then it includes roughly all of the capabilities that a provider would need to meet meaningful use. And then, beyond that, which is this blue square, beyond that blue square, to make clear to folks that in the general universe of EHR technology capabilities, certification still represents a subset. And so to make sure that folks understand that what's required for certification doesn't represent the totality or the universe of all the capabilities that may, in addition, come with EHR technology that's been issued a certification. The other bullets here, that I've listed here in the numerical order are really just different variations of the theme in terms of the quantity of certification criteria that would be implicated by, and most everything below 2 would all be different EHR modules that would be able to support, in some way or another, a provider's achievement of meaningful use. Next slide. Okay, so here's a different cut, a different look at understanding the certified EHR technology definition spectrum. As you can see on the left side with 1 and 2, the green circles there, that's with respect to the complete EHR view. And so complete EHR is going to cover, regardless of whether a provider is in stage 1 or stage 2, all of the certification criteria that would be necessary to support their achievement of meaningful use, with the exception of those optional ones that would, if they choose to meet them, they need to have as well. And then for 3 through 6, these are different variations of the theme on having different quantities of EHR technology certified to different certification criteria. I call it like number 4 as an example where if you take dentists or chiropractors or other EPs with specific scopes of practice, whereby certain core objectives and measures are going to be excluded, or certain menu objectives and measures are going to be excluded, where the interdependence between provider actions that are meaningful use and vendor certifications fits in is that if there's a specialty vendor for dentists, they wouldn't necessarily now, under this new definition, have to get certified for those things that their clients could exclude under meaningful use. And so it's a time and burden savings for the vendors to not have to do work just to get certified, and it's probably a time and cost savings for the providers to not have to possess these additional capabilities that they wouldn't necessarily use to meet meaningful use. So you can kind of look at this. I know a lot of these images are going to be fresh and new to folks. Take a little bit of time and think them through. I hope they help for folks. We can go to the next slide. I'm going to try and wrap up pretty quickly. So the one thing I will leave you with the base EHR definition. From a regulatory construct, it's a definition, and what we found from a lot of the commenters that we got was that folks were treating it as a particular type of EHR technology and referencing it as, quote unquote, a base EHR. So we just want to make clear here that it does not need to be a singular type of EHR technology that is called a base EHR. As if you look back to the prior slide, you'll see in some of those cases where I have brackets, there's actually 2 EHR modules that supply the capabilities for meeting the base EHR definition. And so what we wanted to make clear here was that you don't need to have one particular thing certified for base EHR. It can be, just like with the other larger certified EHR technology definition, something that's met through a combination of EHR modules. I won't go into any specificity for the capabilities that are included here. The one other note is that we did modify the definition, the base EHR definition in the final rule to include specific number of clinical quality measures that need to be included in a provider's certified EHR technology. And so that's one thing that is a new change. That'll be more apparent as I get to the infographic real quickly when we get there. Next slide. Okay, so the one last thing that I'll leave you with at a high level in terms of the certified EHR technology definition. Between now and before the start of the 2014 EHR reporting period, so before fiscal year and calendar year 2014, there are really 3 scenarios in which a provider can meet and have EHR technology that meets the definition for certified EHR technology. The first being sticking with the current definition as it is today, 2011 edition, certified to all applicable capabilities. The second being having basically that option, but in some cases a mix of 2011 edition and 2014 edition EHR technology that's been certified. And so that's that underlined portion where it says equivalent 2014 edition certification criteria. And so then the third is in the case of providers that jump straight to all 2014 edition certified EHR technology, they would be able to pursue the definition really on the right side early. And so that, I think, gives providers a glide path, ultimate flexibility, and vendors also some ultimate flexibility to stagger the rollouts for their customers, as well as to give people that just want to jump ahead, be ready by the end of 2013 to meet meaningful use in the 2014 EHR reporting period. They would be able to jump right away and have EHR technology that could support that effort. I think the rest of the slides I'll probably just let you have for your reference. Some of them reference standards. Others talk about some changes to our permanent certification program. You know, those are covered in the other webinars, or you can catch the webinar tomorrow. I'm sorry, Friday. Is it Friday or Thursday? Or whatever day it is. And that, you know, Travis and I will be doing again in more detail.
Steve,
so you get the next slide over to Travis.
Steve, thank you very much. Travis, I know you and Matthew have been talking about, there you go. So do you have control? Well, let me.
Yes, I do.
Well, you do. Good. So we've asked Travis again. He's got a whole slide deck, and if you the next big seminar open to the public is tomorrow. So we've asked him to not go through slide by slide all 69 slides, but pick, go through the objectives and the ones that he knows you guys are the most interested in, and then you can always jump on the full seminar tomorrow. So Travis,
all right. So
take it away.
First question I have before I get going is to make sure that it looks right to everybody still.
Looks good.
All right. Okay. So as Ned said, I'm really just going to cover, I'm certainly not going to go through every slide by any stretch of the imagination. I'm just really going to hit our higher points, really focusing on the how. So, you know, what is, I'm sure everybody's familiar with what is in the rule now. We do have changes to Stage 1, Stage 2, obviously, CQM changes, payment adjustments, and the Medicaid program changes, which all have to do with patient volume and who's eligible. So Stage 2, what it means to use, there is new criteria moving forward, improving patient care. So basically, the second bullet is really kind of how I describe Stage 2. We hope, our expectation is that Stage 2 will be unsurprising to most people in most objectives, so very foreshadowed natural progressions, you know, things moving from menu to core, things moving from 50% to 80%. You know, some of the clarifications that have been done through FAQs now becoming part of actual regulations, things like that. The three real areas were really pushed, if you will, in Stage 2 were clinical decision support. You know, increased it greatly, put a lot more structure around on the certification side around what it means. Link them to CQMs where possible on the meaningful use side. But by far, the two biggest areas are definitely care coordination and patient engagement. And I'll talk, those are really the two areas I'm going to focus on when I actually talk about Stage 2 as opposed to walking through the various objectives. Eligibility didn't change. That's the biggest message. You know, it was set in law. It was highly unlikely that it would change. We did tweak the hospital-based eligible professional definition for there's a very small group of providers out there who got on board very early with developing their own in-house EHR before hospitals really had EHRs widely, and they use those in the hospital. So if you find yourself in that case, neonatologist is the most common specialty, although it's certainly not the only one, then there is the ability to basically provide an application to CMS and become non-hospital based. Small group of people, this is one of those, if you have doubts on whether you meet it or not, you probably don't. All right, so stage 2 is our timeline for stage 2. This is for Medicare EPs. So, as we said, the most important thing to remember about the meaningful use timeline and path of stages is it is personal to you. Medicare, Medicaid, doesn't matter. It's personal to you. Everyone starts in stage 1. Everyone gets each stage for at least 2 years. Once you start your stages, once you start going, you start your timeline. So even if you skip a year, then your timeline keeps moving without you. So for instance, if I start my first year in 2013 and I test for my 90 days, but I don't pull it off for a full year, when I come back in for 2015 under Medicare and Medicaid, I would be doing my stage 2. I'd be doing stage 2. For the payments itself, that's a little different between Medicare and Medicaid. Under Medicare, I would have lost this $12,000 payment you see there. Under Medicaid, I'm actually allowed to skip years, so I wouldn't lose that payment. But as far as meaningful use goes, once you start that path, the path is started. The expectation is you will stay on it. All right, hospitals, same thing. Start when you do. Start when you start, 2 years at least for each stage. Changes from stage 1 to stage 2, this is the broad overview, basically a shift to the core, but the total number of actual objectives staying roughly the same, or exactly the same. Changes to overall policies, a big one on menu objectives, exclusions. It used to be, and still is through 2013, that if you claim an exclusion, it counts for one of your 3. So if I can go back a slide here, so I have to do 3 out of 6 under the, well, I guess it would only apply to here to the old policy. So right now, I have to do 5 out of 10. If I meet the exclusion, it can count as one of the 5. Under the new policy for stage 1 and stage 2, starting in 2014, if I meet an exclusion, that just means I need to do 3 out of 5 of the ones that are left, or 5 out of 9 if I'm still in stage 1. That's a big shift. It could impact some people pretty dramatically, so we want to make sure to get that out there. If you do wind up in a situation, it's only possible for EPs. Hospitals don't have enough exclusions to end up in this situation, where you have more than 5 objectives in stage 1 that you meet the exclusion for, or more than 3 objectives in stage 2 that you meet the exclusion for, well, then you would just attest to 4 exclusions and 2 objectives if you're in stage 2. Things that didn't change, same eligibility requirement of 50% of outpatient encounters must occur at locations equipped, and then you limit your meaningful use to those locations. Measure compliance always equals objective compliance. Denominators, depending on the measure, either include all patients or only those whose records are in Cert. Certainly don't need to talk about the first bullet, since we just talked about that. Steve just talked about that. The timing change, there was the quote-unquote delay that, was practically required by the fact that we released it in August. We couldn't have anybody start on October 1st of this year. But in addition to that, we added some flexibility, basically in the response to the comment that having everybody upgrade on the same day, especially for EPs when the day is January 1st, just wasn't practical for the vendors or the providers. So what we did was we instituted a 3-month reporting period. One of the other big comments we hear is about alignment. So we wanted that to be aligned with other programs, and in order to do that, rather than doing any 90 days, it's now 3 months aligned with the quarters. So, January through March, April through July, so on and so forth, through whatever it is, May, June. So that's where it's going to be. That'll hopefully allow people to phase out their rollout and potentially give them an additional 9 months to get going too if they waited all the way to the end. We are going to institute batch reporting for, let's just stage 2 batch reporting. We'll let anybody batch report in stage 1 or 2 starting no later than 2014. So all the batch report is, it's still individual EP information. However, we'll let you put it several EPs, hundreds of EPs if that applies to you in one file, and upload it to the attestation system as opposed to sitting there and typing through the screens for each EP. All right, so this is where my self-control comes in, and I try and move through these quicker than normal. On this list, really the big thing to mention that I didn't mention already is CPOE, that and you can't see on the slide, is CPOE is we did expand the who can do CPOE to include certified medical assistants. That was a big issue for our EPs, many of whom run offices with simply the doctor and MAs, so they didn't have other licensed healthcare professionals in their office. On this one, this is our patient engagement. So this is the 5% actually accessing it. So it's real important to distinguish between the 50 and the 5. The 50% is simply that those patients have access to the record. So that means the information is there, it's ready, it's available, and if the patient were to sign up tomorrow, then they would get that information, would be there, and they could then access it. So that's the 50%, is the information available for the patient to create an account and get on board. The 5% is patients who actually have that account, view, download, or transmit that information. Any of those actions would count and put that patient in the numerator for the 5%. We took it down from 10 to 5 primarily just because the concerns that for some people, if you're in Arlington, Virginia, or Southlake, Texas is an affluent neighborhood where I am, you're going to, those docs, my pediatrician, all he's got to do is put this up here. He meets 20%, 30%. He didn't even do anything. Other people, except make it available, other people in less affluent areas or less technology-driven areas, 5% might be a struggle. So we wanted to maintain the principle. So the principle is there. The provider is responsible for patient engagement. However, we took the percentage down because we didn't really see that 5 versus 10% was going to be particularly beneficial in the sense that, it got people who would to do it who wouldn't otherwise, whereas it could be a hindrance for some folks. Our other area is on this slide as well. This is the busy slide, I guess. Summary of care, summary of care documents. So there's really three levels here, right? And there's actually independent slides for these, so you don't have to remember everything I'm saying right now, but I'll say it here. The first level is just the stage 1 move to core. So this is 50% of those transitions of care and referral. I get a summary of care document record to the person I'm referring the patient to or the facility I'm transitioning somehow. I print it off and give it to the patient. My son recently had to go to an ENT. He's 19 months old. My pediatrician, he printed it off, said, when you go see Dr. So-and-so, give him this. That would count in the 50%. So that's kind of the top level. And then we just keep lowering the percentage and adding restrictions and limitations to the numerator that get us more and more to where we want it to be. So for 10%, I want to send it. It needs to be sent electronically using the standards of Certified EHR Technology. This could either be a pull or a push situation. And then the final one is I need to ensure that at least that I can overcome vendor barriers. And I can do that one of two ways. I can say no, find out that one of my summary of care documents that met the 10% went to someone with a different EHR vendor. Or, absent that, and we expect that's how most people are going to do it, right? So in most markets of the country, especially at the EP level, but hospitals as well, there's no one vendor dominates it completely. So through the natural course of business, we suspect most people will meet the first requirement. But if that's not your case, or if you think it's silly to try and find that out, or for whatever reason that one doesn't work out for you, then there's the other option of successfully testing with the CMS test EHR that we will develop long before people need to do this in 2014. All right, so that takes us to the menu. This should look very familiar to anybody who's familiar with the proposed rule, with the exception of progress notes. We did add in progress notes basically because everybody asked us to, and so that is now a menu objective. Everything else here should be pretty familiar from the proposed. Hospitals, I'll mention EMAR, so this is the new objective that is in the core for hospitals that wasn't in the menu from stage 1, and it's just implemented with the assistive technology used for more than 10% of medication orders. This is the same denominator, by the way, that you would get from your CPOE. So you don't have to create, and that's true a lot of places, is you don't have to recreate every denominator for every measure. Some of them use the same denominators. Similar things here for both access and summary of care. Same requirements, EP or hospital. Obviously, EPs on summary of cares will have far more referrals, whereas hospitals will have far more transitions. But otherwise, the requirements are exactly the same. In the menu for hospital, again, notes was added, and provide structured electronic lab results for EPs for more than 20% was added. And really the important thing to remember here that's not on the slide is that the denominator here is electronic lab orders received. Electronic lab orders received, not all lab orders received. So the denominator naturally takes care of many of the problems that people might think for this one of, well, if all my docs are sending me paper, how am I supposed to send them back electronic results? The denominator is electronic lab orders received. 20% of those go back out as structured electronic lab results. So hopefully that our intention in doing that is to make this more attractive to hospitals. We really view this as very important and key to building a robust, meaningful use in terms of labs and spurring both sides of the transaction, both the ordering and the receipts of the information. I'll skip these slides because obviously we already did this. Took a closer look at both of these. Changes to stage 1, I won't spend a lot of time here. Basically, you can just read the slides and see them. Special notes on the bottom of the slides about when it's available. Is it optional? Is it required? Is it optional only in 2013? Is it required in 2014? Or is it like for CPOE, optional going forward, period? All right, CQMs. I'm not going to spend a ton of time on this because I'm not a CQM expert. I'm really going to focus on what's being reported and how it's being reported as opposed to any individual CQM or how they were selected. So we took it out as a core objectives of the incentive program for the obvious reasons of, it was kind of redundant in the attestation system. It seemed, from a regulatory perspective, it seemed like a good idea to have it as its own objective, but when you actually built the attestation system, it became obvious that it was just redundant. So we took that out, and then we're aligning it with as much as possible with our other programs starting in 2014. This shows that alignment, PQRS, CHIPRA, ACOs, hospital inpatient quarterly reporting program are all the programs we considered for alignments. This is what alignment means to us. Same measure for different program measure sets. If you think about this, is probably the most important one because building out the measure is, the toughest part of this. The next two really speak. The next one really speaks to being able to do that. And if you want the same measure for different types of program, you need to have all the different program stakeholders involved in choosing and designing those measures. And then, secondly, but also important, try and find ways that they come in through one submission method and requirement. you all know the benefits of alignment, so I won't waste our time with those. We did align the CQMs with the priorities. So the CQMs, when you select them from your from the list of possible ones, you need to cover at least 3 of these. You know, there's no mystery here. You don't have to figure out which goes with which. There's a table in the rule. There'll be education materials that tell you this measure goes in this bucket. And this is where said list will be. Starting in 2014, everyone who's not in their first year will need, whether they're in stage 1 or stage 2, will need to report electronically to CMS. The stage 1 folks will still use attestation because dealing with the any 90-day EHR reporting period for electronic submission is just a nightmare. So if you're in your first year, you're doing your any 90 days, you still do attestation. Everyone else, regardless of stage, 2014 electronic submission. This is the what you'll be turning in, so you can read the slide as well as I can. You know, so you're looking at 9 for EPs, 16 for hospitals out of a menu covering, as I already mentioned, the 3 domains, at least 3 domains. We will have a recommended but not required core for EPs to try and move people towards consistency in the ones they choose for reporting, but again, not required. So this is a rather busy slide that talks about how you'll actually be submitting what we just talked about. There are lots of different options. I already mentioned the first year. This first group, option 1 and option 2, are essentially the option 1 is really the only EHR specific way. So if you do option 1, that's the EHR incentive programs only. Option 2 is basically you participate in the PQRS EHR reporting option and we give you credit in the EHR incentive programs. Similarly with the group reporting options, participate in the shared savings program as a pioneer ACO using Cert. Using Cert, you do have to use Cert to get credit in the EHR incentive program, but if you do that for ACOs and for PQRS group reporting, you'll also get credit in the EHR incentive program. So really you can think of it as if you don't participate in any of the other programs and you're just looking to do the EHR incentive, then you're looking at option 1. If you participate in either of the other programs, then you probably want to be looking at options 2 or the group reporting options. Hospitals, same thing. You can participate. You can do the EHR only one, option 1, or you can do the IQR pilot and do both in option 2. Timing, we kind of already went over that. You know, the quarters, the important thing to note here is the submission period is at the end of the year, regardless of if the reporting period was a full year or not. This is all for electronic reporting. And that's just basically a slide about what I just mentioned. And this is about how we selected the core. We won't go into that in the interest of time. 2013, remember it's the same. There are ongoing pilots. Feel free to participate in those. Otherwise, everybody will be doing attestation. Payment adjustments and exceptions. I'm going to go through these really fast because there's essentially only 5 questions you need to be able to answer about payment adjustments and exception. And Congress answered 3 of them for us, so there isn't much debate or no debate. One is who's affected. It says there right there on the slide. So Medicare only EPs, subsection D, hospitals and COS. So if you're a Medicaid-only EP or a Medicaid-only hospital, then this doesn't apply to you. If you're dually eligible or if you're a Medicare-only EP or subsection hospital, it does. So that's the who. The other thing you want to know is how much are the payment adjustments, when do they take effect, what do I need to do to avoid them, and then are there any exceptions? So we're going to walk through those questions, especially the first 3 really fast here. So this is basically the slide that talks about the who and the what. The who is Medicare EP, subsection D, hospitals. The what I need to do is I need to become a meaningful EHR user. Talk more about that in detail. But this slide is basically to point out that adopt, implement, and upgrade is not meaningful use, obviously, and therefore it doesn't count as meaningful use. but you can become a meaningful EHR user under either program, Medicare or Medicaid. So this slide is the how much for EPs. And I won't read through the whole slide. It's somewhat self-explanatory. It's basically you find what bucket you fall into in what year, and it works very simply. So on 2016, Part B physician fee schedule, I'm only going to get 98%. So if I submit a $100 claim and I'm subject to the payment adjustment, I'm going to get $98. Most people who talk to you about the EHR incentive program will not be able to answer the question, is X service under the thing? It's all services under the Part B physician fee schedule. What is in the Part B physician fee schedule is a billing question, not an EHR question. So really, if you insist on asking us those, we can forward them on. We won't know off the top of our head, but frankly, the providers billing folks will know better than almost anyone. All right, so we blew through the first 3 questions, as I said. Now we're going to focus on what I need to do and when to avoid them. The most important thing to remember about meaningful use is it's the same definition, the same stage timeline, the same thresholds, the same everything for the payment adjustments as it is for the incentives. So to avoid the 2014, if I've demonstrated meaningful use for the first time in 2011 or 2012, I will have to do meaningful use 2 years ahead of time, 2013, 2015, 2014, 16, 15, and it should be 18 there at the end. It says 4-year EHR reporting period. That's true for every year but 2014, as we've already talked about with the 3 months. If I do it for the first time in 2013, same thing, except, of course, it's my first year, so I get my 90 days in 2013. If I just want to avoid the payment adjustment, give me my drop-dead date. Here's the slide that gives you your drop-dead dates. You must attest successfully, no later than October 1st, 2014, which means they must begin no later than July 1st, 2014. We recommend that absolutely no one do this because that means everything will have to go right for you in attestation and everything else on one day. Certainly encourage people to do this much faster, but that is the drop-dead date. Excuse me. If you are eligible for both programs, you can demonstrate meaningful use under either program. However, you must do it by the timelines we just went through. Subsection D, everything's the same for subsection D hospitals, except we're on the fiscal year and the how much is different. So this slide pretty much explains the how much. It's somewhat self-explanatory, so I'll just move on. As you can see, same timelines, same drop-dead dates, just moved up to the fiscal year. CAS, how much for CAS is different. CAS are reimbursed 101 reasonable costs on a final cost report, and that gets reduced to 100%. Their timeline is different. CAS don't submit claims, so the reason we have to do prospective for subsection D hospitals and for EPs is because the cost of reprocessing the claims, both to us and to the provider, is prohibitive. Since CAS operate on reasonable costs, they can convert over to various things. So their interim payments versus their final payments already vary by more than the %. So they have their performance periods aligned with their payment adjustment periods because they have this unique cost reconciliation process. Hardship exemptions, biggest thing to remember about these is, with one exception, you have to apply for them. You'll apply based on circumstances in 2013 through the application date, which is July 1st, 2014 for EPs, April 1st, 2014 for hospitals. Can't apply yet. This is all based on circumstances that happen in 2013, so there's nothing to apply for right now. Infrastructure, basically internet, and we fully recognize that just because you can send email doesn't mean you can do meaningful use and have a full-blown EHR. So that would be a demonstration of new EPs for the obvious reason. They haven't had the opportunity to demonstrate meaningful use for. Unforeseen circumstances, these are just our natural disasters, or my vendor went out of business, I'm bankrupt, that type of stuff. That really brings us to 4 and 5. 4 is lack of face-to-face or telemedicine interaction with patients and lack of follow-up need with patients. This is one where you would essentially be attesting that you either have none of these or it is in no way part of your normal course of practice to have both of these. The main reason for this is it's much easier to meet meaningful use if you can ask the patient questions directly to fill out some of the recording aspects and things like that. As HIE grows and becomes more robust, this may no longer become a significant hardship, but certainly for right now and until future rulemaking it is. Number 5, is EPs who practice at multiple locations demonstrate lack of control over availability of Cert. Again, the important thing to remember here is if you do not practice in multiple locations, you cannot apply to this one. There is, we basically say in the final rule, we cannot envision a situation where the payment adjustment, you practice in only one location, the payment adjustment is going to directly affect you, and you have no significant influence over the control of Cert. Those 3 things just struck as not possible. Most of the times people have 1 in 3, but the payment adjustment will hit the people who have control of it, not the EP themselves. So, but for our multiple location folks, this is our surgeons who work in ASCs, our geriatricians who work in nursing homes as well, our nephrologists who work in ESRDs, things like that. If they don't have control over the availability of Cert for more than 50% of their patient encounters, they can apply for this one. This is for our folks who don't have to apply. If your primary specialty is anesthesiology, radiology, or pathology, you are assumed to meet the lack of face-to-face or telemedicine and lack of follow-up need for patient hardship exemption. This is an annual determination that we'll check again on July 1st each year. That exception is not limited to these specialties. These are just the specialties that don't have to apply. Any EP can apply for this one if they feel they meet the criteria. Hospitals, the hardship is exactly the same type thing. New infrastructure, unforeseen circumstance. I've already talked about when they're applying. This is the slide for your reference. Medicaid specific, I'm no Medicaid expert, so I'm going to spend very little time on this. I'm actually not even going to use the slides. Basically, 2 things are happening. There used to be a problem, or there is a problem, until this rule fixed it, where a lot of claims for Medicaid beneficiaries weren't actually paid by Medicaid. Either they were paid by somebody else, they were paid by the beneficiary, they weren't paid at all, and the provider just didn't get paid for them. Under the old rules, those didn't count in the patient volume. Under the new rules, they do. The other thing, and I can fast forward to that slide real fast, is that there were 12 children's hospitals out there who are not enrolled in Medicare at all, and they didn't, because they didn't have that number, they couldn't apply. We're going to create fake numbers for them so that they can apply. There's our resources page, and with that, oh, we already did that part, so I guess it's question time.
Travis, thank you. We've got a couple questions. I know we're right up against the clock, so we'll do 1 or 2, and then we'll get back to folks on through the portal or directly with the other questions. But I think a lot of the questions that were typed in, folks covered in their presentations. Here's one, though. Steve, you still with us?
Yep.
Steve, you on?
Yeah, I'm here.
Gotcha. Okay, so this question, though, Steve, really deals with the whole complete EHR, and even though practices may not do something like syndromic surveillance, do they still need to buy that part of the module? And obviously, we don't know what the vendors are going to do. Are they going to roll it all in? Are they going to charge piece by piece, which we assume they might? So here's the question. Say your 2014 Certified EHR and it's 2013, you're not doing syndromic surveillance. Do you still need to buy the complete module, the module? It's one I sent you.
Yeah.
And you can rephrase it if you want to fill it in.
Sure. Yeah. So I mean, the generalizable question is, if I go to adopt 2014 edition EHR technology that's been certified to the 2014 edition, And I'm going to take scenario 3 as I described in fiscal year, calendar year 2013, where I just jumped to using all 2014 edition technology. Do I need to have a component that I wouldn't necessarily use to meet meaningful use, say syndromic surveillance, because it's in the menu set, and I don't plan on meeting that menu objective? Do I still need to have that capability to meet the Certified EHR Technology definition in 2013? And the answer would be no, generally. The one caveat or additional point that I would express is that as I mentioned in my presentation, there's an interdependence between what EHR technology developers seek to get certified, because that's up to them, and they know best what capabilities that they can include in their product or take out of their product in order to get a certification. So in a case where an EHR technology developer gets an EHR module certified to the solely across the board to 2014 edition certification criteria, and it doesn't include syndromic surveillance, then the provider wouldn't be in the position or wouldn't need to have that capability if they weren't planning on meeting that meaningful use objective and measure. If the vendor has a product that includes syndromic surveillance and that is what got issued the certification, then that product that would be what would be available to the provider to adopt. And so that's really where I think, to the point I made earlier about vendors, EHR technology developers having an opportunity to rethink what's going to be the best fit for their customers would, in terms of how this would play out. But generally speaking, the rule is framed now in such a way that the answer would be no.
Good. Okay. Again, we're over time, so Travis, I'm going to ask you to take this last question on. It's really more direction. I know you guys have put together a lot of materials, crosswalks of quality measures to other programs. So are you guys continuing to do the crosswalks with similar quality measures for things like ACOs and chipper programs? Is that information available on your website somewhere?
Well, yeah. So there aren't. This is the classic tension between do you publish the rule as soon as it's done, or do you wait till all the education materials are out? We always default to publishing the rule as soon as it's done. So we're rapidly putting out more and more materials about crosswalks and things. They're a limited availability right now, but generally speaking, those things will come out very rapidly over the next few weeks.
Okay.
And certainly we want to align those, and the spec sheets obviously for the objectives will be in that batch in the next few weeks too.
Excellent. So I'm sort of a shameless plug for the whole collaboration between ONC and CMS. We will definitely they've already started on a couple of the outreach and education COP and the meaningful use COP, putting links on their pages in the portal, and being able to continue the dialogue and the discussion as these fact sheets come out. The folks in the field start using them. If they have feedback, they can bring them back to you guys. So we'll continue to monitor and get that information out to folks. I know, Travis, that you guys have also agreed to talk to the Meaningful Use COP and even talk through how we're going to get the burning issues to you from the field directly and more involvement there. So thank you. Thank you for that. And we've got some calls coming up in the next couple of weeks on that. So more to come, folks. We're over the hour. So thank you so much for hanging in there with us. Travis, you and Steve, thanks again. Keep your voices toned up. I know you're doing presentations, but I appreciate you jumping in just for the ONC grantees. With that, we're going to sign off. Matthew, thanks so much for hosting us. And we'll continue to, I'll send the unanswered questions to the speakers, and we'll get the answers back out on the portal. Thanks, everyone.
Thanks.